Good evening, everybody. Welcome to the Rehabilitation Science Group. Today, we are again with a very interesting topic, knee joint osteoarthritis management. I would like to say it is a bread and butter for the physiotherapist is there. And today, we are having with us Dr. Roshan Lal Meena to take this lecture. Dr. Roshan, I would like to take your consent. We are going online for your lecture.
Okay.
Thank you, Dr. Roshan. Dr. Roshan is a proud alumni of NIOH, and he after that he did his master's in physiotherapy from IMR, and presently Dr. Roshan is working as a senior lecturer in IPH, Institute for Physically Handicapped, Delhi, and sir is having more than 22 years of the clinical and the academic experience. Sir has published his two books. One is on the exercise therapy, that is the exercise therapy principles and practice. Its third edition has come, and sir has published one book on the electrotherapy, that is the electrotherapy principles and practice. Its first edition has come. Sir has been actively involved in the research. He has got a lot of national and international publication, and he is quite active into the ministry works and all. We welcome you, Dr. Roshan Lal Meena, on YouTube channel. Thank you for sharing us your knowledge. Thank you. Dr. Roshan, sir.
Shall I start?
Yes, sir.
Okay. Good evening. Today we'll discuss on knee joint osteoarthritis and its management. Osteoarthritis is a very common disease which usually begins after fifth decade of life, and almost all the individuals are affected by the disease if they live long. Disease commences with the mild symptoms like pain and stiffness in the joint, and these symptoms progress moderate to severe like difficulty in movements, difficulty in walking, difficulty in stair climbing and descending, and difficulty in functional activities. The deformities in the knee joint like varus deformity, valgus deformity, anteversion of the femur, the rotations of the tibia or tibia torsons, all these deformities can be seen in the knee joint in patients with the knee joint osteoarthritis. There is a great role of physiotherapist in the management of osteoarthritic knee joint, where the physiotherapist can prevent the deformities to further progression, and physiotherapist can correct the deformities to some extent, and we can improve the functional limitations and the quality of the life, the quality of the patient. In this session, we'll discuss on three aspects: the knee complex biomechanics, knee complex osteoarthritis, and knee joint osteoarthritis management. So first of all, the knee joint complex. There are two terms, knee joint and knee joint complex. Knee complex consists the tibiofemoral and patellofemoral joints, whereas knee joint is the tibiofemoral. So it is better to consider the knee complex because osteoarthritic condition involves both the patellofemoral and tibiofemoral joints. So instead of knee joint, we should call it knee complex osteoarthritis. What are the joint stabilizers? Because it is very important to understand the stability of the joint. Knee joint is a very important joint as it transfers the weight of the body to the adjacent structures and provides movements which are essential for the activities of daily living, like walking, standing, stair climbing, descending, and functional activities. All these activities depend on the stability of the joint. The knee joint is more stable in the 20s and 30s, but as there's progresses, the stability of the joint decreases. For example, an athlete who gives his best in the 30s and 20s, but after that his performance decreases gradually. This is because after late 30s, the stability of the joint decreases. Like a 70-year-old male or individual cannot run as fast as he would run in the 30s or 20s. This is because at the age of 70, there are a lot of degenerative changes in the joint, lot of osteoarthritic changes in the joint, and because of these osteoarthritic changes, the joint is not stable. Stability of the knee joint is provided by two structures, static stabilizers and the dynamic stabilizers. Static stabilizers are those structures which do not contract, but they provide the stability to the knee joint at rest as well as during the activities or during the movements. These static stabilizers are the collateral ligaments, which prevent excessive angular movement of the knee joint, the cruciate ligaments, which prevent the anterior and posterior translation of the tibia. If there is excessive translation of the tibia, if activity demands more translation of the tibia, these anterior cruciate ligament and posterior cruciate ligament prevent the anterior translation, excessive anterior translation as well as posterior translation. The menisci, which provides cushion to the knee joint and acts as a shock absorber. The cartilage itself is a static stabilizer. So all these static stabilizers keep the articular surfaces in their position. They prevent the excessive movements, whether it is angular movement or translatory movements, whatever it is. These movements are prevented by these excessive movements are prevented by these static stabilizers. See the cartilage, white color cartilage. The dynamic stabilizers are basically the muscles. Muscles are also known as the drivers of the joint. When they contract, movement is produced at the joint. And these dynamic stabilizers or muscles make the joint stable and
Dr. Roshan, kindly unmute yourself.
Okay, is it fine?
Yeah. Yes, sir.
Is it? Okay.
Yeah, now it's fine, sir.
यहीं से start करो पहले से. Shall I start from here?
Yeah, from here only, dynamic stabilizer.
Dynamic stabilizer. So dynamic stabilizers generally keep the or maintain the stability of the joint during the motions or activities. Now, what is osteoarthritis? Osteoarthritis, osteo means bone, arth means joint, itis means inflammation. So inflammation in the joint is known as osteoarthritis. But this definition is wrong actually, because osteoarthritis is not an inflammatory disease. It is a degenerative disease. So if we say that inflammation in the joint is known as osteoarthritis, this definition is wrong. So practitioners and authors have given the new term osteoarthrosis. And osteoarthrosis is the better term, and I personally prefer osteoarthrosis over osteoarthritis. So osteoarthrosis or osteoarthritis, both the terms are used by the authors and clinicians interchangeably, but the meaning is same. Now we can define osteoarthrosis or osteoarthritis as osteoarthritis is essentially a non-inflammatory degenerative disease of the articular cartilage, which is characterized by thinning and destruction of articular cartilage, new bone formation, and capsular fibrosis. The first structure which is involved in osteoarthritis is the cartilage. And destruction of the cartilage usually starts after fifth decade of the life. This is the normal phenomena which cannot be stopped. Primary osteoarthritis is a normal phenomena which has to occur after fifth decade of life, and all individuals will be affected if they live long. So it's a normal phenomena, nobody can stop it. We can delay the process. In some individuals, primary osteoarthritis may occur at the age of 50 or 55 or 60, and some individuals may show the symptoms after 60 years or 70 years. So the process can be delayed, but all the individuals experience primary osteoarthritic changes if they live long. Secondary osteoarthritis, the wear and tear process or the destruction of the articular cartilage may be earlier than the primary osteoarthritis. Say, primary osteoarthritis begins after fifth decade. The secondary osteoarthritis may begin 10 to 15 years before the primary osteoarthritis. And this secondary arthrosis is not a normal phenomena. It is because of some uh, injury, trauma, fracture, underlying pathology, or obesity. All this can cause or put excessive load on the articular cartilage and can damage the articular cartilage at the age of 35 or 40 years or 45 years, but before the primary osteoarthritis or before the 50 years. Now, what is pathogenesis? How osteoarthritis begins, how it affects the articular cartilage, and what changes occur in the cartilage, and how deformities occur in the knee joint. To answer all these questions, first we should understand what is articular cartilage, because osteoarthritis is a disease of cartilage. So whatever changes occur, initial changes will be seen in the cartilage, and then after, because of this cartilage destruction, we can see the changes and deformities in the other structures. So we should understand what is cartilage. Cartilage actually is a gel-like structure which is non-compressible, and this articular cartilage is composed of three substances: proteoglycans, collagen fibers, and water. And water contributes up to 80% to the articular cartilage. So major portion of the cartilage is the water, and 20% is the proteoglycans and collagen fibers. Now question arises how the shape is given, how the shape is maintained, how the stiffness is maintained. Proteoglycans and collagen fibers maintain and they give the shape and stiffness of the cartilage. They maintain the shape and stiffness of the cartilage. And if the cartilage is stiff, it can resist the repeated mechanical stresses. This is the typical feature of articular cartilage. Unfortunately, after 50 years, the collagen fibers break down, and there is a failure of the collagen fibers network. These collagen fibers maintain the shape and stiffness of the cartilage, but unfortunately, after 50 years, they fail to maintain the stiffness and shape of the cartilage because the concentration of the concentration of the collagen fibers is reduced in the cartilage. In when the concentration of the collagen fibers decrease, the concentration of proteoglycans increase. And when the concentration of proteoglycans increase in the cartilage, these proteoglycans attract the more water molecules. Already 80% water is there in the cartilage, but because proteoglycans increase and the collagen fibers decrease, so proteoglycans attract more water molecules. Therefore, the water concentration, the water molecules in the cartilage is increased. This leads to abnormal expansion of the proteoglycans, and there is swelling in the articular cartilage, or articular cartilage becomes swollen. Because of this higher concentration of water, it is more than 80%. Therefore, the stiffness of the cartilage decreased, and the cartilage loses its shape. And this cartilage becomes less resistant to the repeated mechanical stresses, and the process of cartilage disintegration begins. This, therefore, the important part is that the proportion of proteoglycans, collagen fibers, and water, which should be there, is disturbed after 50 years. And because of this, there is abnormal expansion of the cartilage and swelling of the cartilage. The stiffness is decreased now, and this cartilage fails to the repeated mechanical stresses. Now the water concentration in the cartilage is increased. Therefore, small fragments of the cartilage detach from the superficial zone of the cartilage, and these small fragments enter into the joint space where they are eventually degraded. Eventually, because some part of the cartilage is detaching in the form of small fragments, so eventually there is loss of thickness of articular cartilage. The thickness which should be there, the normal thickness, which is reduced in the process of degeneration. There is progressive loss of thickness of the articular cartilage, and there is the defensive mechanism in the body. Because of this, there is a revascularization of the peripheral part of the cartilage, which does not transfer the weight. Revascularization occurs at these sites, and this revascularization forms the osteophytes. So osteophytes are projected at the peripheral part of the cartilage or the joint. These osteophytes may project to the ligaments or the synovium or the capsule, and they can put the pressure on this structure. So patients may experience dull type of pain. Now see, this is the cartilage, and this part of the cartilage is damaged, or the thickness of the cartilage is reduced or lost. So the next part, which is a subchondral, is exposed here. Now, the weight which is transferred on the articular cartilage is not being transferred on articular cartilage. It is transferred on the subchondral bone, because subchondral bone is exposed. And this is the reason that when there is complete loss of thickness of the cartilage, patients experience pain. See, this is the articular cartilage, this is superficial zone, this is middle zone, and this is a deep zone. So initially there is a loss of thickness of the superficial zone. This part is lost, and as the disease progresses, the middle or transitional zone, which is up to 40 to 60%, is also lost. So we, at the end, when there is complete loss of thickness of the cartilage, the subchondral bone is exposed. Now weight is transferred on the subchondral bone. So when the weight is transferred on the subchondral bone, the pressure is transmitted to the cancellous bone. So when the pressure comes on the cancellous bone, some material, some part of the cancellous bone come out, and that forms a cyst. So if there is cyst on X-rays, it shows advanced osteoarthritic changes because cyst is formed by the cancellous. It's a part of cancellous bone. Sometimes cyst is formed in the joint space, and sometimes it is within the joint, within the bone. This is the white substance is the cartilage, and this is the subchondral bone, and next to the subchondral bone is the cancellous bone. Now, we discussed on the cartilage because osteoarthritis is a disease of cartilage and how cartilage is destructed, and when the cartilage is destructed completely, how the subchondral bone is exposed, and when the weight is transferred on the subchondral bone, the pressure is transmitted to the cancellous bone. So some part of the cancellous bone come out and that may form the cyst. Now we'll discuss on why osteoarthritic changes occur in the medial compartment of the knee joint. Why these changes, osteoarthritic changes, not common in the lateral compartment of the knee joint. This is because the medial compartment, which is formed by the medial epicondyle of femur and the medial condyle of the tibia, the size of the medial epicondyle of femur is greater than the lateral epicondyle. Because of this, the medial compartment transfers more weight than the lateral compartment. And there is a general rule that the structure which transfers more weight will be more vulnerable to the osteoarthritic changes. The structure which does not transfer the weight or transfers less weight will be less vulnerable to the osteoarthritic changes. So this is the reason that the medial compartment transfers more weight than the lateral compartment. Therefore, medial compartment is frequently involved in the osteoarthritic changes. Now, because medial compartment is involved, and in osteoarthritis, the thickness of the cartilage is reduced. When the thickness of the cartilage is reduced, there is exposure of the bone. So when thickness is reduced, there is approximation of the bones. The subchondral bone of the femur and subchondral bone of the tibia will come closer. And because of reduced cartilage thickness, these medial compartment bones come together, and that results in varus deformity of the knee joint. So medial compartment is involved because it transfers more weight, and because of this, there is varus deformity. Now, varus deformity is associated with the medial rotation of the tibia. When there is varus deformity of the knee joint, the tibia rotates medially. So the proximal tibia will rotate medially. And when this proximal tibia rotates medially, the Q angle will decrease. So in patients with osteoarthritis, especially when the medial compartment is involved, you will see the medial decreased lateral rotation of the tibia, or the tibia rotates medially and the Q angle is decreased. Now, to compensate this, the distal tibia rotates externally, and you can see excessive pronation of the foot. So the patients with knee joint osteoarthritis will have varus deformity, especially when medial compartment is involved, and there is medial rotation of the tibia or decreased lateral rotation of the tibia. And to compensate this, there is lateral rotation at the distal tibia, and the foot goes into the hyperpronation. Whereas to assess the varus deformity, we can draw a line, we can have X-ray of the patient and draw a line from the acetabulum to the medial anterior midline of the ankle joint. So normally this line passes through the anterior midline of the knee joint. When this line passes through the anterior midline of the knee joint, it means there is no deformity. But if the line which is drawn from the acetabulum to the anterior midline of the ankle shifts laterally, it means it's a valgus deformity. And if this this line shifts to the medial side, it means there is varus deformity. So in patients with osteoarthritis, you will see that the line which is drawn from here to here shifts medially. This indicates varus deformity. What is reverse screw home mechanism? Screw home mechanism is a mechanism in which when we extend the knee joint, especially at the end or terminal extension, the tibia rotates externally. This external rotation of the tibia is to lock the knee joint. This is a normal phenomena and it is known as screw home mechanism. But in patients with knee joint osteoarthritis, screw home mechanism is compromised because the lateral rotation, which is considered 23-degree in normal subjects, normal adults, external rotation is 23. In patients with osteoarthritis, this lateral rotation is decreased to the 20-degree or 15 degrees. When this lateral rotation is decreased to the 15 degrees, during the terminal extension, tibia does not rotate externally. When it does not rotate externally, the knee joint cannot be locked, or we cannot achieve the full extension, which is essential during the walk, because when we walk, there is full extension at the knee joint, and because of this, the ground reaction forces are equal to the body weight. So in patients with osteoarthritis, there is reduced external rotation of the tibia, so patient is not able to lock the knee joint. So what patient does to compensate this mechanism, patient rotates the femur medially. So when patient rotates the femur medially, now the angle, which is 23 degree in the normal adults, can be maintained because anteversion or internal rotation of the femur can compensate the external rotation of the tibia. So instead of rotating the tibia externally, femur is being rotated medially. This is known as reverse screw home mechanism. Synovial degeneration or popliteal cyst. In patients with knee joint osteoarthritis, some patients show popliteal cyst. Popliteal cyst is not common in patients with osteoarthritis, but it may be there. How this popliteal cyst is formed? In osteoarthritis, there is formation of osteophyte. These osteophytes may project into the synovium. So there is pressure on the synovium. Synovium goes under the process of degeneration. So there is degeneration in the synovium. Unfortunately, the fluid in the joint comes out of the joint space into the popliteal fossa through the synovium. And in the popliteal fossa, it forms a cyst. Gradually, it accumulates and forms a cyst that is known as popliteal cyst. So if there is a popliteal cyst and patient complains pain in the knee joint also, especially in the medial compartment and the patellofemoral joint, so this cyst may be because of degenerative changes or osteoarthritic changes. Patients experience acute pain. Patients experience acute pain, and this pain does not respond to the heat modalities, your IFT or ultrasound. So we can recommend cryotherapy here, but some patients do not respond to the cryotherapy also. So if this situation is there, then we can refer the patient to the orthopedician for aspiration of the fluid. After medial compartment involvement, there is involvement of the patellofemoral joint also. The articular surfaces of the patellofemoral joint undergo degenerative changes. Normally, the patella moves on the patella rests on the trochlear groove, and this moves on the trochlear groove during the flexion and extension of the knee joint. This is known as normal tracking of the patella. Unfortunately, because of anteversion of the femur or medial rotation of the tibia or lateral rotation of the tibia, or increase or decrease Q angle because of shortening of the muscles, the patella, instead of trochlear groove, it moves either on the lateral epicondyle of the femur or medial epicondyle of the femur. This is known as patellar maltracking. So patellar maltracking is one of the regions of patellofemoral osteoarthritis, and this patellar maltracking may be because of some anomalies in the bones, some deformities in the knee joint because of tibiofemoral joint osteoarthritis, or because of shortening of the muscles. This is the lateral maltracking of the patella, and in many patients, the patella is shifted laterally because the lateral part of the patella is connected with the lateral retinaculum, and lateral retinaculum connects with the tensor fascial lata or TFL. So in some cases, there is shortening of the tensor fascial lata. So shortening of TFL pulls the lateral retinaculum, and lateral retinaculum pulls the patella laterally. So in these cases where TFL is short or lateral retinaculum is short, the patella moves on the lateral epicondyle instead of trochlear groove. When the patella moves on the lateral epicondyle of the femur, the ground reaction forces on the lateral epicondyle of femur increase. Therefore, more wear and tear will be there on the lateral epicondyle of femur. And the general rule is that the part which transfers more weight will be more vulnerable to the osteoarthritic changes. So we can see the osteophyte formation, the decreased joint space here, and lateral tracking of the patella. The patellofemoral osteoarthritic patients may show swelling in the anterior aspect of the knee joint. Here we can see the sulcus, folds of the skin. Here we cannot see because there is swelling. There is swelling here. Now, how can we grade the osteoarthritic changes on radiology? X-ray grades or radiological gradings of the osteoarthritis. The grading is 0 to 4, and 0 is considered normal. There is intact joint space, there is no deformity, no sclerotic changes, no osteophytes are there. When the joint space is intact, normal, no doubt in the mind, it means it's a normal or grade 0. Grade 1 is narrowing of joint space, but it's doubtful. You are not sure that the joint space is decreased, but the joint space is decreased. And possibly you can see the osteophytic changes. Possibilities are there that osteophytes will be there, but not sure. So grade 1 is very uncertain or doubtful, but joint space is reduced. On grade 2, definitely osteophytes are there, and definitely the joint space is decreased. You will see reduced joint space and osteophytes on the unshared areas, especially in the peripheral structure. Osteophytes not formed in the joint space. Osteophytes are formed at the peripheral structures or the intact cartilage, area of the intact cartilage, or unshared areas. Unshared areas, the area which do not transfer the weight. So this part is intact and osteophytes are formed at the unshared areas at the peripheral part. So on grade 2, you will see definitely joint space reduced and the osteophytes. Grade 3, moderate multiple osteophytes and definite narrowing of the joint space. In addition to these two, there will be some sclerotic changes and possibility of deformity at the bone ends. So if sclerotic changes are there, this is grade 3. If sclerotic changes are not there, but joint space is reduced, that is grade 2. And grade 4 it is addition to the grade 3, where we can see large osteophytes, marked narrowing joint space, but severe sclerotic changes. In grade 3, you will see the sclerotic changes, but in grade 4, you will see severe sclerotic changes, and definitely you'll find a deformity. Deformity may be translatory or angulatory, like valgus, varus, or you can see the rotations of the tibia. So on grade 4, you will see the deformity and severe sclerotic changes, and subchondral cyst may be present, because grade 4 is the advanced stage where there is complete loss of the thickness of the cartilage and exposure of the subchondral bone. So because exposure of the subchondral bone, pressure is transmitted to the cancellous bone, some part of the cancellous bone come out, and that form the cyst, or cyst may also be formed within the bone. This is the normal joint. You can see the space here, and this space is actually the cartilage. Cartilage maintains the joint space. Here, the space is decreased. Sclerotic changes can be seen on this X-ray. You can see the lipping or the osteophyte formation here. The joint space is reduced here. At this, on this X-ray, you can see opening of these articular surfaces, excessive opening of these two articular surfaces, and there is complete loss of joint space here. There is like a fibrosis, and you can see the osteophytes here. So this is grade 4. Sclerotic changes can also be seen. This is grade 3. This is normal. Now, what are the symptoms of osteoarthritic knee joint? Pain is the most dominant clinical feature of knee joint osteoarthritis. Stiffness, which can be seen when the disease initiates, but this stiffness decreases because pain dominates the other features. So in grade 1, we can see pain and stiffness, but in grade 3, 4, you will not see the stiffness. Pain will be the dominant feature. Stiffness can be seen when patient rest for a prolonged period of time, like 1 hour, 2 hour, and when they get up, they feel little bit stiffness. So stiffness will be there, that kind of stiffness. Difficulty in moving the joint. When they flex or extend the knee joint, they find difficulty in moving. Difficulty in walking, or there will be pain on walk, and difficulty in straight climbing, descending, and performing the activities of daily living. These are the symptoms of osteoarthritic knee joint, which progress gradually as the disease progresses. Now, what are the biomechanical changes seen in patients with osteoarthritic knee joint? Whereas, because medial joint space is reduced, valgus is not a common deformity in knee joint osteoarthritis. decreased lateral rotation of the tibia, because varus is associated with the medial tibial rotation or torsion. So lateral rotation of the tibia is decreased, and screw home mechanism is compromised. Knee extension lag. Knee extension lag is when patient finds difficulty in obtaining terminal extension. That is the knee extension lag. But this terminal extension can be done passively. That is the lag. And in patients with knee joint osteoarthritis, this is very common. Why? Because the lateral rotation of the tibia is reduced, which is essential for terminal extension. And if the patient does not rotate the femur medially, then there will be impingement between the uh, tibia and femur. So patient will find difficulty in achieving the terminal extension. And if patient does not achieve the terminal extension, there will be extension lag. Extension lag is very common, and this is a disability, very uh, knee flexion lag. There is restriction in the flexion, excessive pronation of the foot, that is a compensatory, and reverse screw home mechanism, that is to compensate the lateral rotation, femoral anteversion, that is also compensatory, and we can see anterior tilting of the pelvis and increased lumbar lordosis. Management. Okay, management. On management, here we'll see what are different exercises which can be recommended to the patients with osteoarthritic knee joint, and how these exercises can improve the pain, functional limitations, and disability of the patient. How these exercises can rehabilitate the patient and bring back to his or her normal routine. Because osteoarthritis has a significant economic and societal impact on individual from morbidity and loss of productivity. So management is targeted to rehabilitate the patient, to reduce his symptoms and bring him back to his normal life, normal official duty. Now, why for this, to rehabilitate the patient, why exercises are given? Exercises are basically to improve the strength of the muscles, because muscles are the dynamic stabilizers of the joint. And if these muscles are weak, joint will no longer be stable. As I told you earlier, that stability should be there. If the joint is not stable, joint will not perform the functions. The individual can stand, but not for long time. To perform the functions smoothly, efficiently, and effectively, the joint has to be stable. And so to provide the stability to the knee joint, we have to strengthen the muscles. So, and we also know that the muscles are the drivers of the joint. And if they are weak, joint will no longer produce the movements required for the activities of daily living. Therefore, in order to improve the stability and mobility of the joint, improvement of the strength of the muscles remain the cornerstone of the therapy. It's a prime goal of the therapy. How exercise is initiated? Can I start the vigorous exercises, or what exercises should be given to patient X who whose grade is 1 on X-rays, or same exercise can be given to the patient who has advanced osteoarthritic changes. So how these exercises started? The intensity of exercises depends on the age and health of the patient. Exercises are progressed from minimal load to the moderate and to the maximum load on the joint. However, all these exercises depend on the grades of the osteoarthritis. Treatment depends on the examination and the stages in which the patient reports the clinician. I have given three examples. The first is if the osteoarthritic patient comes in the early stage, it means there is grade 1 osteoarthritic changes. So if patient comes in the early stage where there is minimal degenerative changes, these patients can be managed with the vigorous exercises. But consider the age. The patient should not be elderly or 70-year-old or more than 65 years. So if patient is less than 60 or 65 and degenerative changes are there, but these changes are minimal, then we can start the vigorous exercises. If patient comes with reduced joint space and moderate marginal osteophytes with no obvious deformities, joint space is reduced, moderate marginal osteophytes are there, then the focus is given to reduce the pain and symptoms while avoiding excessive load on the articular cartilage during the exercises. And if patient comes in the advanced stage with gross joint space reduction and massive osteophyte formation, in these cases, the focus remains on the ambulation of the patient and improvement in the functional limitation. We cannot expect here that the patient will run. No, there are severe degenerative changes. So in these cases, we have to move slowly, gradually. This is the progression of exercises. Irrespective of stage, we can advise isometric exercises. Isometric exercises will not produce the symptoms, will not aggravate the symptoms. And even if patient comes in the advanced stage, we can recommend the isometric exercises. And there is no reason of delaying the isometric exercises. There are therapists who say that exercises will aggravate the symptoms, so we'll first try to reduce the pain, and then when pain reduces, we can start the exercises. No, this is wrong. Start the isometric exercises when patient reports to you in the first visit. These exercises will not aggravate the symptoms. In fact, isometric exercises will help in reducing the muscle spasm and the pain. After that isometric exercises, we can progress to the closed kinetic chain exercises, then open kinetic chain exercises. Then we can progress to the stretching exercises and the conditioning exercises. Now, isometric exercises, these exercises are taught to all the patients irrespective of the stage. There is no restriction of isometric exercises. We can recommend these isometric exercises to all the patients irrespective of their stage, whether it is advanced stage or early stage of osteoarthritis. Recommend these. We can reduce this intensity of exercises if symptoms are severe, but you can start isometric exercises at the first visit of the patient. Because muscles are the dynamic stabilizers, they are also known as drivers of the joint. So if your drivers are weak, you cannot perform the movement. So we have to strengthen the drivers so that they can drive the joint, they can move the joint, they can produce the movements at the joint. So first is the quadriceps sets exercise. We place the towel under the knee and then ask the patient to contract the quadriceps while keeping the knee joint on the towel. The patient extends the knee joint by elevating the or raising the ankle. So this ankle will slightly or will raise over the this plane. This is quadriceps set isometric exercise. This is also same exercise, but we can see the elevation. The, the, this patient raises the foot from the plinth this much. So because this patient is thin, muscle bulk is less, so we can see the movement here. And this roll, tall roll can also be increased. When we increase the tall roll, we can see the more movement. For the quadriceps sets, important is the knee should be on the tall and the ankle should be raised over the plinth. This patient should not raise the knee over the tall. This should be over the tall. This is a gluteus sets exercise. This very simple to this exercise. A tall roll is placed under the knee joint and patient is asked to press the tall by not raising the ankle joint. In quadriceps, we raise the ankle joint from the plinth. But here the patient is pressing the tall and keeping the ankle joint on the plinth. So gluteus maximus is contracting, pushing down the tall is the action of the gluteus maximus. This is a gluteus sets. Hamstring sets, the knee joint is flexed, ankle is dorsiflexed, and then we ask the patient to press the plinth and press the plinth and flex the knee joint. When patient flexes the knee joint, the position of the heel on the plinth is maintained. The heel remains on the plinth while flexing the knee joint. When patient flexes the knee joint, there is contraction of the hamstring muscles. So this is isometric contraction of the hamstring muscles. This isometric contraction of hamstrings can be done at various angles. This is almost 90 degree. We can do this exercise at 30 degree, 40 degree, 60 degree, whatever range is available at different angles. Straight leg raising for the quadriceps, iliopsoas. This also allows contraction of the abdominals. So initially, when there is pain in the knee joint or if a weakness is there, then we can hold this SLR position at the 30 degree. But as the strength increases, we can increase the SLR position to 50 degrees. And if the patient is young and there is no pain in the lower back region, we can go for both the SLR. Both the legs are raised. This will allow contraction of the abdominals, and abdominals are the core stabilizers. In patients with osteoarthritis, there is anterior tilting of the pelvis, means weakness of the abdominals and gluteus maximus. So we have already strengthened the gluteus maximus. For the abdominals, we can ask the patient to raise both the legs. This is prone SLR for the gluteus maximus, and this can be done against the resistance. This side SLR, initially we can do at 20 degree, then it can be progressed to the 60 degree or 50 degrees. So these isometric exercises are basically to improve the strength of the muscle so that we can increase the stability of the joint. A closed kinetic chain exercises. The first exercise is mini squat. Why closed kinetic chain exercises? Why not open kinetic chain exercises? Closed kinetic chain exercises are because, for example, a mini squat, there is co-contraction of the two group of muscles, the hamstrings and quadriceps. So this co-contraction of the muscles help in providing the stability. In this position, the hamstrings also contracting, and that hamstring is pulling the proximal tibia posteriorly. So that's maintaining the stability of the knee joint. So this close kinetic chain exercise allows co-contraction of the group of muscles. Mini squat is preferred over the half squat and full squat. This is because mini squat places approximately 2 to 3 times of the body weight on the articular cartilage, whereas half squat places 4 to 5 times of the body weight on the knee joint. And when we go for the full squat, the load on the knee joint comes approximately 7 to 8 times of the body weight. And general rule is that we have to avoid the load on the articular cartilage. If there is more load on the articular cartilage, there will be more distraction of the articular cartilage. So here, mini squat is enough. Mini squat means up to 30-degree flexion of the knees. And this mini squat helps in strengthening the gluteus maximus, the quadriceps muscles, hamstring muscles, and the abdominals. Then we can progress to the, if there is improvement in the sign and symptoms, patient is responding to the treatment, then we can progress the mini squat to the half squat. But for the half squat, we have to consider the age of the patient. Patient should not be uh, 65 and above. So if it is less than 65, we can go for the half squat, but that should be, the back should be supported on the wall. Then this is a mini squat, and this exercise is for the a mini to half squat, and this exercise is for the vastus medialis obliquus. Vastus medialis obliquus is a dynamic stabilizer of the patellofemoral joint. Patellofemoral joint has only one dynamic stabilizer, that is a VMO, vastus medialis obliquus. And this VMO prevents the lateral translation or lateral tracking of the patella, because lateral tracking or lateral tilt of the patella is very common because there is shortening of the TFL. TFL is connected with the lateral retinaculum. So lateral retinaculum pulls the patella laterally. VMO stabilizes the patella or the trochlear groove, and this prevents lateral tilt of the patella. Therefore, rehabilitation of VMO is very important. For strengthening of the VMO, we place the ball or the towel roll between the knees or thighs, and then we ask the patient to bend the knees. The adduction of the hip joints help in strengthening the VMO, because VMO is the extension of the adductor muscles. So by adducting the hip joint, that can fire the adductors and strengthen the vastus medialis obliquus. This full squat without back support is not advised, because in this position there will be 5 to 6 times body weight on the cartilage. So don't recommend this exercise, especially if the patient is 60 plus. Don't recommend this squatting exercise. Don't recommend cross-leg sitting and straight climbing, because straight climbing can place 5 to 6 times body weight on the articular cartilage. And even if you are recommending stair climbing, you must consider the height of the stair. It should not be more than 6 inches. If it is more than 6 inches, that will produce more load or ground reaction forces on the patellofemoral joint. So don't recommend this. Isotonic exercises. These exercises are given to the patients who report improvement in symptoms after the isometric exercises, or there is minimal pain or improvement. We can recommend isotonic exercises like this. In supine lying, the flexion and extension of the knee joint. In supine lying, we can ask the patient to raise the leg or SLR, side SLR. In prone, we can ask the patient to raise the leg. So all these exercises are the isotonic exercises, which will not put additional load on the knee joints. Now, what are the open kinetic chain exercises? When there is improvement in pain and symptoms, we can progress to the open kinetic chain exercises. And open kinetic chain exercises are considered to produce more load on the articular surfaces. And these exercises should be recommended if there is improvement in the signs and symptoms, there is improvement in the movement, there is improvement in the functional activities. This is very simple. This will not produce more load, but when we go knee extension against the resistance can be given in the form of a tubing or TheraBand or the weight cuff or the dumbbell. We can tie here weight cuff and we ask the patient to extend the knee joint. So this will strengthen the quadriceps. Ultimately, the aim of therapy should be to strengthen the muscles, but strengthening is progressed steps to step. You cannot recommend these open kinetic chain exercises directly to the patient. That can aggravate the symptoms, especially if the population is elderly or 60 plus. So we move step to step. This quadriceps training with the tube. Now stretching exercises. Due to pain in the joint, patients avoid movements as movements cause pain. And if the movements are avoided for a long period of time, that results in shortening of the muscles. Now, these shortened muscles further limit the movements or reduce the movements, which leads to deformities like extension leg or flexion leg. Therefore, stretching exercises are initiated to increase the flexibility of the muscles and to improve the movements. It is there that we must respect the pain, but it should not be there that we should avoid the movements. And if the movements are avoided for a long period of time, definitely there will be shortening of the muscles. So these shortened muscles will reduce the range of motion further. So the aim of therapy should also be to improve the flexibility of the muscles so that we can gain the ranges. This is quadriceps stretching exercise, hamstring stretching exercises. This also stretches the back extensors. Hamstring stretching exercises. This is for tensor fascial lata stretching, which is very important, especially if patellofemoral joint is involved. Recommend this tensor fascial lata stretching. Piriformis stretching. Now, how to improve flexion? Restriction in the flexion is very common in patients with osteoarthritis. This is because involvement of the medial compartment of the tibiofemoral joint or involvement of the patellofemoral joints. So pain in the patellofemoral joint will not allow the patient to flex the knee joint completely because knee flexion will put the pressure on the patellofemoral joint. So if pain is there, patient will avoid the flexion and gradually there is limitation in the flexion range or extension lag, flexion restriction. So how to improve the flexion? Generally, physiotherapists consider passive stretching of the quadriceps to improve the flexion range. But this is not the right step. In many occasions, this flexion or stretching of the quadriceps, passive stretching of the quadriceps, aggravate the symptoms. Therefore, there is an alternative of the passive stretching, which does not provoke the symptoms. In fact, that's very effective and instantly increase the flexion range if the flexion range is limited because of shortening of the quadriceps. And that is the contract relax exercise. Hold relax is generally given to the patients where there is severe muscle spasm or like DOMS. So hold relax is more effective in DOMS. But in patients with osteoarthritis, knee joint osteoarthritis, contract relax exercise is very effective, and this is a PNF stretching technique. To perform this technique, suppose flexion is limited. This is 45 degree, and beyond 45 degree, patient cannot flex the knee joint. When we flex the knee joint passively, there is pain in the knee joint. By using the contract relax technique, we flex the knee joint up to whatever range is there. Suppose 45 degree flexion is there. So we flex the knee joint up to 45 degree and hold it firmly. After that, we ask the patient to extend the knee joint. So to extend the knee joint, patient will contract the quadriceps muscles. And there is a theory that strong contraction of the muscles is followed by same degree of relaxation. So when patient contracts the quadriceps against the resistance, we can allow some movement here up to 45 to 40 degree or 38 degrees. So this arc is allowed. Patient contracts the quadriceps and there is some movement. So this contraction of the quadriceps relaxes the quadriceps. Now after count of 6, we ask the patient to relax the quadriceps and then we flex the knee joint. Now you will see that the knee flexion is improved to 47, 48 degrees. Then again at the 48 degrees, hold the knee joint, hold the leg and ask the patient to contract the quadriceps and small arc of movement can be allowed. After count of 4, 5, we ask the patient to relax the quadriceps. Again, we flex the knee joint. Now you can see up to 50 degrees. You will see that the flexion range is increased. This is a very effective contract relax exercise, PNF, which was given by the Dr. Kabat in 1956. Mobilization with movement. In this technique, we see that because of degenerative changes, there are some translatory movements. And if these translatory movements can be corrected, we can improve the symptoms of the patient. So in a mobilization with movement, there is a lateral glide of the tibia here. This can be given in this. First, we'll see this. One hand is placed over the distal femur and the other hand is placed on the proximal tibia on medial side. The patient applies a force couple against each other. So this hand presses the proximal tibia, which results in lateral glide of the tibia. So this lateral glide helps in improving the symptoms. Lateral glide can also be given with the belt. The examiner or the therapist uses the belt and the body momentum for the pressure. So when patient leans backward, there is a lateral glide of the tibia, and this lateral glide can be uh, with the movement of the flexion and extension. This is also Mulligan technique or mobilization with movement. We hold the proximal tibia and rotate it medially, and then we ask the patient to flex and extend the knee joint. This also improves the range of motion, especially flexion. Now, a knee extension lag, this is a very common disability which may be seen in the elderly patients. And if knee extension lag is there, these patients walk with the knee flexion. And anybody who walks with the knee flexion can put more stress or load on the patellofemoral joint. So anyone who walks with the knee flexion will have more ground reaction forces on the patellofemoral joint, and patient finds difficult. They can, after 10 minutes or 15 minutes, they cannot walk. So correction of knee extension lag is very essential for the physiotherapist. If we are focusing on strengthening of exercises, we are focusing on all the core stabilizers, but not correcting the extension lag, it means we are not in the right direction. Patient is not getting the right treatment. So correction of extension leg should be the priority of the therapist, because if extension leg is not corrected, you cannot improve the walk of the patient. Patient has to walk with the intalgic gait. Patient will walk with the pain. So correct the extension leg. To correct the extension leg, we can place the towel roll under the ankle joint, and then the patient can press the knee joints downward. This will stress the posterior joint capsule and improve the extension leg. The extension leg can also be corrected like this. Place the leg over the chair or stool and then let the knee go downward. Or slightly you can apply pressure. If severe pain is there, don't apply pressure. You just keep the ankle over the stool and gradually let it go downward. This very simple technique, just lie on tummy and relax the hamstring muscles. So this will stress the posterior joint capsule and improve the extension leg. And if patient is attending your clinic, you just make the patient sit like this, hold the leg and stabilize the distal femur and extend the knee joint. So this will stress the posterior joint capsule, because posterior joint capsule fibrosis or shortening will limit the extension. So terminal extension is limited, number one, because there is reduced lateral rotation of the tibia. And because of this, when patient avoids the terminal extension, there is shortening of the posterior joint capsule. And this shortening will limit the terminal extension. So stress the posterior joint capsule. Now, aquatic exercises. Aquatic exercises are basically given to the elderly people who find difficulty in standing on the ground or not able to walk on the ground. And these patients do not want to go for total knee replacement. So for these patients, we can recommend aquatic exercises. There is a buoyancy effect, and buoyancy effect is upward force, which reduces load on the knee joints. When the load on the knee joint is reduced, there will be less pain. So when we get these exercises done in the water, the patient experiences low intensity of pain, and in water they can stand and walk When these patients walk against the resistance, against the water, resistance is applied by the water. So there is strengthening of the muscles also. So we can strengthen the muscles, we can improve the range of motion in the water, and after 10 to 15 days, these patients are made stand, walk on the ground. And it's very good that they can stand without pain. They can walk few steps, and gradually their walk can be improved. Now, gait training exercises, after improvement in the sign and symptoms, we can ask the patient to walk with the walker, and after that, when patient gains the confidence, we can remove the walker and advise stick. Patient can walk with the stick. Now, the conditioning exercises. What are the conditioning exercises? If there is improvement in pain and extension leg, if there is improvement in functional limitations like standing, walking, stair climbing, and descending, if patient gains confidence on standing and walking, then we can progress to the conditioning exercises. These conditioning exercises are basically advised to maintain the functional functions, range of motion, and activities of daily living gained during the rehabilitation. So that should not be there that we have achieved uh, this much, and if we don't go for conditioning exercises after 1 month or 2 months, patient will come with the previous stage, with the pain and difficulty in walking. So we condition the patient for the activities of daily living, or whatever he does in the office. For the conditioning, walk is the safe exercise. We recommend walk because during the rehabilitation program, we have improved the pain, we have improved the range of motion, we have improved the functions of the patient, functions of the joint, or functional limitations or activities of daily living. Therefore, now we can recommend the walk. Walk is the safest exercise, and walk does not produce extra load on the articular cartilage. Walk not only improves the strength of the muscles, but also helps in cardiovascular exercises. It also reduces the or burns the fat. So walk is a very good exercise. Recommend if there is no pain in walk, recommend this walk or a morning walk or evening walk to these patients. Cycling, those have static cycle in their home, we can recommend this static cycle. And treadmill, stair climbing. Initially, we did not advise stair climbing because there was pain, difficulty in walking, stair climbing. So during the rehabilitation program, our aim was to improve the strength and stability of the muscle. Now, because strength has improved, now we can condition the muscle. Suppose a 50-year-old stays on second floor. Now he has to come down or climb the stairs once or twice a day. So we have to condition the muscles for that activity. We can ask the patient to go for jogging, running. So this was a little session for the osteoarthritic knee joint. Thank you very much for joining. I thank Dr. Shagun and all his colleagues for giving me chance to speak on this platform. Thank you very much. Thank you all participants for attending this webinar. I wish you all very happy and healthy life. Thank you very much.
Thank you, Dr. Roshan Lal Meena, for a wonderful and a very informative session on knee osteoarthritis. I think every physiotherapist must watch this video and keep it for long-term management perspectives of knee osteoarthritis. Thank you so much for this wonderful knowledge and sharing it. with
Thank
your
you very
fellow
much.
professionals and students. Thank you.
Thank you, sir. Thank you very much.
Thank you, Dr. Roshan, for sharing your knowledge. Thank you.
Thank you, sir.
It is a wonderful lecture. Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you, sir. Thank you. Thank you very much.